My name is David G. Short. I'm an otolaryngologist, a specialist of the ear, nose, and throat disorders. The specific areas of otolaryngology, of course, are related to the ears and the diseases of the ear, outer and middle and inner ear, including vertigo or dizziness. The nasal cavity, of course, would include the nasal passage, the breathing, the sinus cavities, the smell associated with that. The throat, of course, would include throat or mouth, tonsil, tongue, membranes inside the mouth, and of course the larynx, which is your vocal cord region, the area of speech, the area that allows you to get air into your lungs. And then lastly, we do reconstructive surgery, some plastic surgery, which is more dealing with the nasal fractures or fractures of the face, skin conditions like skin cancers. We do all of those. Allergies are typically seen during the allergy season, spring and fall, but there's a subset of patients that have allergies year-round. There's allergies that can be indoor allergens, like animals, dust, molds, and of course we all know about the outer allergens, the pollens, grass, trees, flowers. So people can suffer mostly all year long or have a specific season. So whenever they're having symptoms is when we typically see them. Well, the symptoms of treating a patient with allergies is to avoid that allergen, but sometimes it's hard to avoid an allergen. You're going to be outdoors, or you're going to still be in your home that might have some indoor allergens. So avoidance is the number one. Number two would be manage the allergies with medication. Typically, we'll use antihistamines. There's a drug called a leukotriene inhibitor, most commonly called montelukast. That's typically added to any allergy protocol. That kind of just helps the allergy medication work better. We also use nasal inhaled steroids like Flonase, those kind of products. And that'll give you relief, especially temporarily relief of an attack. Sometimes we'll go with oral steroids. That also gives you a better response to an allergen. And lastly, if things don't work that way, allergy testing, where you get pricked on the skin and find out what allergen you're allergic to, and might lead to allergy shots. So the trigger factors can be multiple. They can be something inhaled through the air, you breathe it in, something you touch, or something you eat. So that's typically how you get an allergen. The most common area, believe it or not, for an allergen is the eye. When people have it on their hand and they rub their eye, a lot of the allergens are transmitted into the mucosa of the membrane of the eye, and it enters your body. Yes, of course, inhaling it through the nose can be another source, and rarely through the mouth, unless it's an allergen to something you've eaten. For example, you're allergic to strawberries. You're going to have a rash or symptoms of an allergy from that meal that you had. Sometimes people don't know they have an allergy to foods, and they keep eating the same food and having the same symptoms. That's why sometimes testing is so important. Reconstructive surgery in otolaryngology is dealing with the midface. The midface is the space between your upper lip and your brow. That's the midface. That's where your eye sockets are at, your cheekbones are at, the nose is in the middle. That's typically the trauma we receive when we get hit in the face, car accident, somebody hits you with a stick or their hand. You're going to break those areas, either break your nose or break your cheekbone. And that's what we reconstruct. We'll put the nose back in place, of course, repair those nasal fractures. Of course, we do lacerations. We do a lot of lacerations on the face where people fall and cut their head, or there's a car accident where you just rip the skin. We do plastic surgery to reconstruct those regions, but we do not do cosmetic surgery, which is a big difference. So we have to fix the nose. We'll fix the nose so it looks good, but we won't lift that tip to give you that very nice, good-looking tip that a cosmetic surgeon would give you. The most common one is what's called a rhinoplasty. A rhinoplasty is actually correcting the nasal injury. Typically, a patient has broken their nose either recently or in the past. They have a bump they don't like, or the nose is crooked. We'll put the nose back in the middle. But again, not cosmetically. The tip typically will not be addressed. And that's more of a cosmetic type of procedure that is not covered by the insurance company. So we'll do a procedure to help you look better, maybe breathe better. That is covered by insurance companies because we're affecting function, not the looks. Quality of life would be if it's also affecting the breathing. A lot of times when there's been a nasal injury, it also affects the inside of the nose, called the septum. The septum is the middle divider between both the nostrils, and sometimes it gets shifted to one side, and it'll affect the ability to get air. So that really affects function of a patient because they can't get good air through the nose, especially when they lay down to sleep. Their mouth is open and they're breathing through their mouth all night long. Of course, the outside, a lot of people have a self-conscious about how they look, especially if they have a crooked nose or a nose that has a big bump on it, and that will fix. We'll make their nose straight on the outside. If there's a bump or a hump, we'll reduce that hump so it looks natural. And of course, if there was an issue with breathing, that'll be corrected at the same time. So the head and neck is typically involving with mass in the neck, typically. Yes, it can occur on the face, but typically a patient's going to come in with a mass on their neck, on the side of their head, the side of their jaw. Typically, it's a benign lymph node that actually is active, but every now and then, cancer is shown up as a neck mass, and we see a fair amount of that, especially cancer that's say in the tonsil or the larynx that has metastasized to the neck. It's a big old bump in the neck, and typically with those kind of patients, we'll try to find the original port where the cancer started. If we don't, then we'll do a biopsy of those neck masses that are there. Other masses that are typically seen in the neck are thyroid problems. Patients will have a large thyroid or a mass on their thyroid, maybe have a goiter in their thyroid, maybe have cancer of their thyroid. So neck masses are an area of our specialty that we treat very carefully because it can lead to major problems if not found out. It's not just a little bump and here's an antibiotic and go on your way. We got to make sure that that's nothing that might cause problems in the future. Typically, the most common one is that big old bumps in your neck. That's the most common. People say, I don't like how this looks. It's not getting better. I've had it for several weeks, maybe a few months. What's going on? So patients are very afraid. I think most people know what lymphoma is, and that's what most people come in and tell me. I have lymphoma of my neck because I have this big bump there. Rare, but we do see some lymphoma. I think that's the most common. People are afraid something's going on. Sometimes it might affect swallowing. Sometimes it might affect the stretching, or sometimes it causes pain. If it's involving a salivary gland, which also can cause swelling of the neck, it definitely affects how they eat. The gland starts to get large, swollen when they eat, and it gets very painful at times with those neck masses. Yeah, so depending on what we think the mass is, and we've done a good ear, nose, and throat examination, if we see that there's something wrong with, say, the mouth, the tonsil, the larynx, the vocal cords, then we start looking and see maybe is there something back there that's metastasized to the neck. If we see something in the larynx or the tonsil, we'll biopsy that area, and pending the results, especially if there's cancer in that area, we know that that's a metastatic process in the neck. But I say we have a completely normal throat and laryngeal examination, then we'll do what's called a needle biopsy of that neck mass to try to get cells. That's when we see our lymphomas a lot, or we'll see a benign lymph node that just irritated for whatever reason. Maybe you have acne, or maybe you have a ear problem, or some other problem that make that lymph node act up. And of course, if there is cancer, we get rid of the cancer in the mouth, throat, wherever it's at. And also sometimes you have to clean the neck and remove all the lymph nodes, just like you would do with any other cancer. So typically a patient with a laryngeal problem comes in with a weak voice, or a horsey voice, or a voice that's very hard to keep in a regular pattern. It changes. The patients usually come in after a few weeks saying they can't speak well, they're losing their voice. Sometimes it's stronger in the day. As it goes throughout into the evening, the voice starts to get weaker. But the main thing we have to do with a voice disorder is evaluate the vocal cords. The vocal cords, of course, are the structure that gives you your voice, and there are two little bands that move back and forth that will vibrate and produce your sounds. If one is affected either with not moving well or there's something on the vocal cord, it'll affect the sound. So typically what we do in the office is what's called a fiber optic laryngoscopy. We'll prepare the nose with medication, and we'll go through the nasal cavity with a very small telescope and go into your voice box and look at the vocal cords. We'll be able to see the function of vocal cords, if they're moving properly, if there's a good, what's called a wave of the vocal cords as you phonate, Typically, we have patients say E, I, O, 1, 2, 3, and then moves the vocal cords in the ways we want to see it. And then we'll see if there's disruption of the nervous system of the vocal cords. Is one vocal cord weaker than the other one, or is one vocal cord paralyzed? So those are the things we see. And of course, a mass in the vocal cord will also affect the ability to phonate. Lastly, a lot of patients will have what's called acid reflux that will affect their voice. Their voice gets a little rough because they're leaking into that region, and the vocal cords get a little swollen. And if they get swollen, they don't vibrate as well, and they get a little horsey. So we also evaluate for that. Most common vocal cord dysfunction is just what's called chronic laryngitis. A cold, some acid reflux, like I mentioned earlier, can cause that. A viral irritation that gets into the vocal cords, causes irritation of vocal cords. Typically, the vocal cord gets a little puffy, a little swollen, and that affects the ability to vibrate properly, and you get a little horsey voice. Of course, we talked about the bad, which gladly are uncommon, are like laryngeal masses. Patients that smoke have a higher incidence of having vocal cord abnormalities, especially tumors of the vocal cord. There's also, of course, what I discussed earlier, paralysis or weakness of the vocal cord. If we do see a paralytic vocal cord, we usually will start looking at the chest, at what's called the recurrent laryngeal nerve, which is a nerve that goes to your vocal cord. It has a really strange path, and it actually goes into the chest and then comes back into your throat. So typically we'll do x-rays of the chest to see if there's something wrong with that nerve, or is it being impinged, or is there something blocking the signal that would give you a vocal cord weakness. The most common thing is to look. And like I said, typically in the office, we'll do a fiber optic laryngoscopy. That gives us a lot of information. That lets me see if there's everything's normal, if it's just inflammation, if there's something more than just inflammation. Is there a weakness of the vocal cord? Is there a tumor in the vocal cord? Is there a polyp, a nodule? A lot of people that abuse their voice, for example, auctioneers, cheerleaders that abuse their voice, they'll form little nodules on the vocal cord. Typically, all we do is give them voice rest, and that usually subsides very nicely. Acid reflux is always looked for because that's a common finding in the vocal cord region where the vocal cords get swollen. Of course, doing surgery would include, if there's a tumor, they're getting the tumor out of the vocal cord, preserving as much of the vocal cords as we can so they don't have to have a what's called a total laryngectomy. We'll take out the whole structure of the larynx, and now they have a little hole in their neck to speak from. And we rarely do that unless a disease, cancer, is very advanced. We'll do partial laryngectomies to preserve the voice. A lot of times just taking the tumor out and maybe radiating the patient if they have cancer, chemotherapy. A lot of times, so our aim is to preserve the voice as much as possible, depending on how advanced the disease is. The ear, of course, is your hearing organ, and it has several parts to it. The outer ear, which is the outside of the ear, which you can see, and the canal that leads to the eardrum is considered the outer ear. Then there's an eardrum, and the eardrum, behind the eardrum is a space called the middle ear. That's where most people get infections. That's where most kids have that fluid in their ear. And then past the middle ear, there's the inner ear, which is where the organ of hearing is at. That's the acoustic nerve is there. And also the vestibular nerve, which is your balance nerve. So there's three parts to the ear. The most common thing that we see, especially in children, is fluid behind the eardrum. Okay, typically we treat them with medications, and typically we get them better. But a subset of those patients do not get better, and sometimes we have to put a tube in their ear to get rid of the fluid, which restores their hearing. In adults, they also can have fluid in the ear, less common than children. And then there's two types of hearing loss. There's what's called a conductive hearing loss. That means that if there's wax or there's fluid or there's inflammation in the canal, it gives you a conductive loss. Get rid of that obstruction, the conduction portion is gone, and you restore your hearing. And then the second part of hearing loss is called a nerve hearing loss, what's called sensorineural hearing loss. That means the acoustic nerve is not hearing well. It could be genetically, or maybe noise-induced, or maybe viral-induced, or maybe you have something blocking the signal from the nerve, which is pretty rare. What's called acoustic neuroma can push the nerve and block the ability of the nerve to hear properly. So all those things are checked by doing a hearing test. So when the audiologist gets that patient that we've seen, she'll do a hearing test. We make sure we have the wax. If there's wax removed, then she'll test the ears. She'll do some special tests to see if it's a conductive loss, fluid, and then she'll do some special tests to see if there's a nerve loss. The key thing is differentiating between both ears as well. So not only will she check the good ear, she'll check the bad ear and compare them. That gives us a lot of information of what's the next step to do, whether medication, surgery, or other treatment options. A hearing loss due to the nerve is hearing loss. That's the most common thing. They'll come in and say, I can't hear properly. A lot of times it's one ear, but they can have definitely both ears. Many older patients, which is the most common population that we see with hearing loss, might be genetically induced. Grandma or grandpa or an aunt or mother had hearing loss, and they're probably going to get some of that. Aging, of course, as we age, all our senses are going to start decaying, whether it's your smell, your taste, your vision, your hearing. Just with age, it's going to get a little bit weaker and not function as good as they did when you were young. And we know that, so we look for that as well. And then, of course, say that you've been exposed to loud noises in your environment. You worked in a factory with a lot of loud noise, your chances of hearing loss is greater because of that environment. Recently, over the last few years, we've been seeing a lot more hearing loss in younger people, and a lot of people are getting that from those headphones that they use or those earbuds that they use with loud noise next to their eardrum, and that affects that hearing eventually. So the hearing loss that I saw in my 65 and 70-year-old, I'm seeing now in my 30 and 40 and 50-year-old people because of that noise that they're exposed to with such close proximity of the noise with their Bluetooths or their earbuds that they're using nowadays. One other thing is that depending on the type of loss, we can actually do a couple of things. A lot of people just need a hearing aid. Great, you do that. Sometimes the loss is due to an infection. Get rid of the infection to get their hearing back. Sometimes, if it's due to something worse, like a tumor, we have to get that tumor out of that ear. The part of the ear examination, especially patients will come in saying they're dizzy, they're unsteady, or they have lightheadedness. And depending on how long, I have many patients come in and say, I've had this for 6 years. Typically, the ear will not give you dizziness that long. The ears are kind of a dynamic structure in that you have two balance systems, one in each ear. And if one of them goes out, you might be dizzy for several weeks, the other ear usually comes in and takes over the balance of both ears until that other one recovers. So typically an inner ear problem is a short event, several weeks, a month or so. And then that recovers even if I don't treat it on its own. So there's several conditions that are a little worse. One is called the Meniere's disease, common condition, mainly in women, that can be long-term and reoccurring. Those can be very bad attacks that people get really disabled with, nausea, vomiting, can't drive, can't talk, can't lift their head. So those, when we look for that, but thank goodness it's not a common problem that we see. So vestibular rehab for a typical balance disorder is what we do. We either do exercises at home that we provide in the office. Sometimes patients cannot do things at home, so we send them to physical therapy, and they'll do those therapies for the vestibular organ, which is your balance system. And typically that usually brings them back out. The bad thing about that is that they'll reoccur months later, and then we do the same therapy again. So it's not like you cure it once and it's gone forever. And unfortunately, it comes back. The most common one we see is fluid in the ear. So the most common one, you have a child, 2-3-year-old kid, has had ear infections in the ear. Family doctor can get the ear cleared up with medication. We see him. We also try a little stuff here and there, but typically we'll put some tubes in their ears. That restores their hearing, and the infections subside. Typically, the tubes will stay in the ear 2 years, then the ear will push it out. And hopefully in that time, since we've given the ear a little bit of a rest, the eustachian tube, which is a main problem with fluid in the ear, will recover, and that ear will be a lot healthier. Another thing that we see with the ear sometimes is a blockage with wax. Every day I see 5, 6, 7 patients to remove wax. And I have actually a lot of repeat customers. Every 3, 6 months they come in, doc, I need my ears cleaned out and my wax is back. And it's an easy procedure that we do in the clinic to help them hear better, especially patients that have hearing aids. Once you start getting a little bit of wax in the ear, it blocks the signal of the hearing aid and it bounces back, and they get a feedback on their ear, on their hearing aid. And that really is really annoying for the patient, so we have to clean those ears more frequently. The most common problem that we see in our adult population is nasal issues. Nasal issues would include sinus issues, obstruction of the nasal airway, difficulty smelling, difficulty just breathing in general through the nose. That's the most common thing that we see. The most common one is an obstructed septum, what's called a deviated nasal septum. Typically, as we go through our life, at some point our nose probably got bumped. Even when you were a small child, you might have fallen and your nose got bumped and the septum got crooked or bent. And eventually that cartilaginous septum becomes more bony, and that becomes like a bony obstruction. So it's hard to get air through the one or both nasal cavities. That's a very, I don't say simple, but a very common problem that we see. A lot of times those patients will have surgery of their nose. It's called a septoplasty, improve their airway. Another obstruction issue that we are seeing that we actually are more diligent or more aware of is what's called the nasal valve. The front part of the nose, there's an area called the nasal valve that sits as you enter the nasal cavity right in the front. It's actually a structure that's there to prevent the nose from collapsing. As you breathe air through the nose wants to shut down or collapse. So we have these little valves that keep the nose patent, open, so air can get through there. Well, as we get older, that gets very weak. And actually, as you take a breath, it actually closes the airway even more. Very noticeable when you sleep. So a lot of these patients come in and say, doc, I'm okay during the day, but when I lay down, my mouth is wide open and I sleep with my mouth wide open, my mouth is dry. Typically, they have a little valve collapse. So when we do a septoplasty, we'll address that area of the nasal valve and fix that. Now, a little further in the nasal cavity, you have 8 sinuses, 4 on each side of the head, and all these sinuses drain into the nasal cavity. Typically, a sinus patient will have pressure in the face, over the eye and the forehead, over the cheek. Sometimes they'll have colored mucus from the nasal cavity, yellowish, greenish, maybe milky in nature. They'll feel like there's a lot of pressure. Sometimes it affects their breathing. Sometimes they'll have maybe a little fever or maybe not feel well because the sinus is infected. Typically with those patients, either we treat them or we do what's called a CAT scan of their sinuses. And that'll show us what's inside the sinuses. And if there's disease that's not going to respond to medication, we'll do surgery on those patients. We do sinus surgery. And the sinus surgery nowadays has really changed from years past in that we do minimal surgery. It's called minimally invasive surgery and get better results. We basically just dilate with balloon dilation, that little opening of the sinus, enlarge it, wash out the sinus, and that enlargement of the sinus opening will allow the sinus to clean itself out. Now, sometimes patients have polyps or other little growths. Those have to be removed as well. But most commonly, it's an infected sinus that's blocked, open it up, they do much better. Patients that come in sometimes indicating that they have sleep apnea. Not an uncommon presentation we have in our clinic. A lot of times patients come in and the wife or the husband has noticed that at times that patient is snoring and all of a sudden there's a gasp for air or there's a delay in breathing. Very typical of a sleep apneic patient. Most people think that sleep apnea is just with larger people, but not necessarily so. We see a lot of young, thin patients that have sleep apnea. The main problem with sleep apnea is actually the tongue. The tongue is actually a muscle that is very movable, as we know. We use it to talk, to eat. It also has a fullness or heaviness in the back. And when we lay down, especially in our back, the tongue tends to fall back and attach itself to what's called the pharynx, the back wall of the throat. And it blocks the airway not only through the mouth, but through the nose. So a lot of times these patients will gasp, catch that breath, or they'll turn to one side or the other to open up their airway. So typically with those patients, once we see there's an obstruction or we have that history, we actually get a sleep study. A sleep study is an overnight process that can be done at home or can be done in our sleep lab. And what that test will show us is that, yes, there's an obstruction. It'll show us if it's mild, moderate, or severe apnea. It'll show us how many episodes in a night a patient is having, how long these episodes are occurring, 20 seconds, 30 seconds. And it also will show us what kind of obstruction or what kind of sleep apnea they have. There's what's called obstructive sleep apnea. 90% of all sleep apnea patients are obstructive. And then central sleep apnea, where the brain itself shuts it off. Those with central sleep apnea are easily fixed either with doing a procedure on the tongue or putting them on CPAP therapy every night. Those central components, which is more of a nervous system, very hard to treat. There's new procedures out there that are what are called implantable devices that go in the neck that stimulate the tongue. And as you fall asleep and the tongue starts to fall back, it'll stimulate the tongue to move it forward so it does not obstruct your airway. Typically in a year's time, we'll do over 100 tonsillectomies in a year, and I would say about 80% of those are children. Commonly, the parents will bring the child in because they've seen large tonsils, or they have issues with their breathing, they'll have issues with their snoring, or their sleeping, and sure enough, they have big tonsils. Of course, a lot of kids also have a lot of strep throat, and they'll see their family doctor 3 or 4 times throughout the year with a recurrent strep throat, and that's an issue that we deal with a lot. So the most common surgery that we do as ear, nose, and throat doctors is a tonsillectomy. That's the number one procedure. I think tubes would be the second, and then third would be nose and sinuses. We also see adenoid problems. So typically an adenoid is a tissue that sits in the back of the nose. It actually is like a tonsil. It's actually a lymphatic type tissue. And sometimes in young kids, the adenoid is an enlarged organ, blocks the airway. So as you breathe through the nose, there's like a little cork in the back of the nose that doesn't let you get air very well. So most of those kids have their mouth open, and they're mouth breathers. Their mouth gets longer. We call it an adenoid facie. It just stretches the face a little bit because they're constantly with their mouth open. And when they sleep, they're very loud in their sleep, snore, or they actually will have sometimes a little difficulty getting air, especially if they also have large tonsils. So when we do a tonsillectomy, especially in young children, we also will do an adenoidectomy at the same time. Of course, for the year, we mentioned earlier that a very common procedure that we do as otolaryngologists is put tubes in kids' ears. Hopefully it's just one set, but every now and then a subset of those patients will need a second set. And typically when we go to a second set, we also will take their adenoid out. And the reason we do an adenoid in a problem with the ears is that the eustachian tube, which is a tube that drains your ear, empties where the adenoid is at. And if the adenoid is large, it will block that ability of that eustachian tube to drain, so the fluid stays in the middle ear. So if I have to put a second set in a child, I usually recommend to the parents that we also do an adenoidectomy to remove that obstruction so we don't need a third set and a fourth set in the future. All newborns are tested for hearing loss. And there's a simple test that's done when they're born within a day or so. It's called an ABR, an acoustic brain response. They don't, of course, at that age, they don't have to participate. We just put some electrodes around their ears like a headphone and stimulate the ears and see if we get a response. I would say the majority of the newborns are normal. It's that abnormal test that we get. And then we do follow up that child probably within 6 weeks and repeat that test. Make sure it was not just an aberrant test. And if we do see a pattern there's a loss, we quickly intervene. Sometimes we put hearing aids in babies because they need to hear. You need to start learning from the time you come out of the womb until you, of course, an adult, for forever is what I'm trying to say. So quickly we'll address that problem with the child so he does not delay in his learning, his development. Thank goodness it's not very common, but yeah, we have a few in our practice that are, 2-3 years old. They've had hearing aids for, a year or two because we caught it early and treated it early so the delay is not there. One other item that I would like to kind of mention that's also very important is in our newborns. A lot of times when I see our newborns 3, 4, 5 days old is for the inability of them to nurse well. I'm sure you've heard of patients having what's called a tongue tie or a lip tie. The tongue tie is there's a frenulum, a little piece of fibrous tissue that sits underneath the tongue that allows the tongue to move up and down. Sometimes that fibrous tissue is very thick and attaches the tongue to the floor of the mouth. And that child is not able to latch on to that nipple and they fall apart or they fall off the nipple or they dribble or they leak and the child does not nurse very well. I typically see those patients very, very early, within a few days, because that child is not gaining weight, not nursing well. And the pediatricians a lot of times will send them to our clinic for us to release that tongue. Very simple procedure in the office. It takes us 2-3 minutes. What we do is put a little anesthetic underneath the tongue. Then we use an instrument to release that frenulum, which is what it's called, tongue frenulum. And that allows the tongue to move freely. And now that child's able to latch onto that nipple and have better suction ability. A second part of that is sometimes patients will have what's called a lip tie, which is the top of the lip. There's also a little frenulum. The little frenulum sometimes attaches to the palate, and what affects that is sometimes the speech will be affected, and sometimes it'll separate the front two teeth because it goes right between them where it attaches to the palate. And a lot of times we'll cut that off to avoid separation of the upper teeth and maybe future affect the speech because they can get a speech impediment since they can't move the lip properly.